Welcome, everyone. Thank you for joining us for Region 11's monthly webinar series. My name is Erica Rocario-Thorpe, and I am part of the Chapter Relations team at HFMA. To kick off the webinar, we would like to thank our sponsors, AmPlus, Commerce Healthcare, Progressive Management Systems, Parallon, Firm, TCF Capital Solutions, Harris & Harris, Extend Healthcare, Access One, HRG, AccuReg, Novus, Mail My Statements, Berlot, Premier, Centauri, TrueBridge, Avidyne Health, Patient Matters, Argos Health, RMC, Enable Comp, State, Sherlock, Aid Bailey, Softtech, OVAG International, and VitalWare. Your participation is requested. There will be a live Q&A during the webinar, so put your questions in the Q&A pod. We'll also be utilizing the chat pod to share information and tips during sessions. And now it is my pleasure to introduce Molly Martin, President for the Hawaii chapter.
Aloha, welcome everybody. Good morning / good afternoon. I know we have people spanning time zones on today's webinar, so thank you for joining us. On behalf of the Hawaii chapter, I would like to welcome all of you to this session titled Meeting Patient Needs, 2021 Opportunities for New Reimbursement, presented by Extend. Extend is a Platinum Hawaii chapter sponsor and has been a chapter sponsor of ours for the last 10 years. Linda Corley is well known to our chapter, and I'm sure many others that are on the phone for her immense knowledge and expertise. Thank you, Erica, for going through some of the housekeeping items. We do want to encourage you to participate and ask questions, so we'll be monitoring that box throughout the session and answer questions as we're able to. Slides will be made available to all attendees and will be distributed to all of the Region 11 chapters after today's presentation. Today's session is also being recorded, and recordings will be made available as well. One minor clarification from what was distributed, we do have CEUs available for this webinar, not CPEs. So if you need a certificate for CEUs, please reach out and we're happy to get that information to you. I now have the pleasure of introducing Linda Corley, who needs no introduction, but here we are. Linda Corley has worked collaboratively with hospitals and physician offices for the past 25 years. She has served as controller of a university-owned 4-hospital group and provided insight into clinical and financial staff members on compliant reimbursement. Linda is a credentialed coder and a frequent HFMA presenter. She's a previous college professor who taught financial processes for healthcare, health information management skills, and billing and collections courses. Linda also has over 15 years experience on the national level of leading CDM reviews, coding and billing audits, and providing consulting services for revenue cycle improvement. She has served as corporate compliance officer for Perot Systems and Dell Revenue Cycle Services. Linda's current role is Vice President of Compliance and Quality Assurance for Extend Healthcare. And without further ado, I'm pleased to turn it over to you, Linda.
Good afternoon, and thank you. Thank you all for joining us this afternoon. We are pleased to offer this information. And I have to tell you, of course, when I begin one of these, I have way too much information for us to go over in an hour, but I like to provide all the details I possibly can so that if you share this with others or if you want to use it as a reference, you can look back and find the specific information that we are going to talk about this afternoon. The other information I would add is this is all about new opportunities for patient charging for services that you may have not been able to charge for before. So I do want to match perhaps new patient needs, particularly based on COVID-19, with these new services that I am talking about codes, but rather than you focusing on the codes themselves, I would just like for you to keep in mind these services that can be charged and billed, not only during the pandemic or the emergency health period that we are in right now, but many beyond the PHE. And as you see there, the public health emergency has been extended through January 23rd. From everything that I read, it will be extended once again. So keeping in mind, as I mentioned, I don't think the codes are as important as you simply understanding here are services that we can discuss with our physicians, we can take to our outpatient departments and clinics, and we certainly can look at for employed physicians. Most often there is a professional component as well as a facility component, which is what I want to get across to you this afternoon. There are some revised regulations, and as you know, during this public health emergency since back in March, we have just been bombarded with not only new codes, but changing regulations and perhaps different billing instructions than we've been able to follow in the past. So again, I think it's important that we take a different view of how we can provide patient clinical needs, not only during this pandemic period of COVID-19, but also as we complete all of 2021. On this page on our agenda, you'll see there that there are probably, I think, 9 or 10 different areas of service that can now be charged and billed. And of course, we're going to talk about these. So I'd almost like for you to use this as just your checklist to see what you can provide to patients, and then to make sure as you are discussing these services with different areas within the hospital, or perhaps even on the outside with your employed physicians, that you are looking at all the opportunities that are available to you. These are the latest developments coming from CMS. You'll notice down towards the bottom of the slide, I mentioned that even on October 14th, CMS did add 11 new telehealth services, and I give you there the link in case you want to go out and look at these new services. And I have an even more updated list of telehealth services that we will talk about briefly. I think the good news for all of us is that along with the public health emergency, CMS and other payers have lifted some of the restrictions that we have been able to charge and bill under in the past. So way back on March 6th, Medicare decided to make payment for professional services being furnished to Medicare beneficiaries in all areas of the country and in all settings. Now that is a great statement for us, because not only lifting the restrictions, it allows varied situations for both patients and physicians or professionals to be reviewed, and generally there is a chargeable service there. And I want to continue to point out, as I mentioned to you, in addition to the professional service, and I think we generally, when we mention telehealth, we think about the professional component, but most often there will be a facility or a technical component for hospital outpatients or provider-based clinics. So I want you to keep in mind as we talk about these services, not just professional services, but understanding the setting in which the services are being delivered, and is there a facility component there that can be charged and billed. And I'll mention again, Medicare now will make payment for telehealth services furnished to beneficiaries in any healthcare facility and in the patient's homes. These visits are considered the same as in-person visits and are paid at the same rate as regular in-person visits. And again, that's an important point for us, because these are paying more. Instead of the previous telehealth rates, we now are allowed to charge and bill these as in-person visits or evaluations. So they are paying a little bit more. We did have an executive order in August to continue telehealth into 2021. And now that has even been clarified to December 31st of 2021. And of course, we know why CMS and other payers wanted to expand telehealth services, simply so that the community spread of the virus of COVID-19 was being limited, and then understanding that perhaps a patient with chronic conditions may not want to come into the facility and receive services, but telehealth, of course, certainly being safer. The current news is that telehealth expansion, as I mentioned to you, as some previously non-allowable services will continue after our public health emergency. I found this recent information in our October edition of HFMA, or HFM is the magazine, and it really brought home to me that if we are using these new services and new codes that are now chargeable and billable, that they will have an impact not only on our revenue, but also on our cash that is coming in the door. So as you see there, the greatest impact, I do think chronic care can be improved through telehealth particularly, but there are some other CPT codes also that we will discuss. And I like that lower cost of care delivery, which of course is always important to us, but understanding how to place these services into our all the services that are being offered and how they can lower cost of care, I think is extremely important. So this slide simply sets out some of the CPT codes, some of the HCPCS Level 2 codes for telehealth. Medicare, up until the public health emergency, defined telehealth as an interactive audio and video communication through a system that allows real-time communication between patients and physicians. As I have already mentioned to you, and I apologize for the repetition, but I want to be sure I get some of this across. These are the questions that I get. So we want to be sure that we are billing either the HCPCS Level 2 code or the CPT code as you normally would if the particular service or visit had taken place in person. And then even on December 1, just 14 days ago, we have another updated list of telehealth services, and I give you the website there to go out and find that list. That list is also published on our website if you want to refer to it. But understanding how telehealth has changed, I welcome the questions. So if you want to send me an email, or even if you want to telephone me, please make sure that you are reviewing, you are discussing, you are understanding for your particular physician or for your area within the hospital or health system, how telehealth is improving patient care. As I mentioned to you, no payment restrictions on the distant site practitioner. Again, please report the place of service code on your 1500 now on your professional claim. Again, I'm asking that you report the place of service that would have been reported had the service been furnished in person. That's an important one because look at that next bullet. This reporting of the appropriate place of service code will allow the Medicare system to make appropriate payment for services furnished via telehealth, which would have been furnished in person at the same rate they would have been paid. So extremely important to us to obtain that additional reimbursement. Which qualified providers are permitted to furnish telehealth services under this particular public health emergency? Of course, the same healthcare providers are still able to furnish Medicare telehealth services. And you see there physicians and other non-physician practitioners, such as nurse practitioners, physician assistants, and certified nurse midwives. But in addition, I think it's important for us to keep in mind other practitioners, such as our CRNAs, licensed clinical social workers, our clinical psychologists, and even registered dietitians or nutrition professionals are also able to furnish telehealth services within their particular scope of practice, and of course, consistent with Medicare benefit rules that apply to all services. So we've opened up these other practitioners that now can charge and bill for telehealth services. The number one question, of course, is do I have to have both audio and video? And the way CMS has answered that is you'll see there in the second bullet, to the extent that many mobile computing devices have both audio and video capabilities that may be used for two-way, real-time interactive communication, they do qualify as acceptable telehealth technology. And again, if you want more information, you see the website there where CMS speaks specifically to the type of communication that is required. And I think this is a confusing area for us. It is called technology-based communications services, and we're going to look at some of these. But look at that bottom bullet point, because CMS did clarify what patient-initiated service truly means. During this public health emergency, remember that it has been elongated through December 31st of 2021. Patient-initiated means the patient must orally consent to the service either before or at the same time that it takes place. It does not prohibit a practitioner from educating beneficiaries on the availability of the service prior to or even at the same time that the service is taking place. So again, a relaxation of what has been required. And I think this allows us to reach out to a patient, offer a communication-based technology service, and ask for the patient's consent, which we'll talk about in just a second, but simply being able to educate, request consent, and then provide the service all in the same sitting or the same encounter, I think is extremely valuable to us. The OCR, the Office of Civil Rights, did let us know on March 17th that they will not impose penalties for non-compliance with the HIPAA rules in connection with a provider having a good faith effort to promote telehealth communications during the emergency. And again, an important one to us, and a question that I get often, if I'm using this device, a smartphone or a laptop, an iPad, how do I know whether or not I'm meeting the particular HIPAA guidelines or rules that are in place? Well, of course, you want that conversation to be private. But I do think even the OCR, the Office of Civil Rights, sending us this information is important because I think the care of the patient is what comes first in this circumstance. So here are those communications technology-based services and what CMS is telling us must take place. Of course, we need documentation. That will come as no surprise to you. But look at what CMS is asking us to document: that the visit occurred via telemedicine or a specified type of that technology-based service. We do need to have documented the physical location of the patient, the physical location of the provider, keeping in mind that, wherever they are located, that is acceptable. The names of all the persons participating in the telemedicine service and their role in the encounter. And that's important, I think, because if we allow another practitioner or professional to step in and provide services, we want to be sure that we have all the facets of that particular service documented, and we are reviewing to be sure that we are charging and billing appropriately. So a documentation example to identify a particular telemedicine visit might be: the visit was conducted with the use of interactive audio and video telecommunication system that does permit real-time communication between the patient and the provider. The patient did provide oral consent. If, for example, it's a virtual visit, we want to document the date that consent was obtained. We want to document also the origination site, the location of the patient, and the distance site, the location of the provider. Keeping in mind, if you build your telemedicine template in your EHR or electronic health record to ask these particular questions, that will generate appropriate documentation for the services that has been provided. Again, this slide is all about the question, how does a healthcare provider bill for telehealth? You see those first two bullets there that we have discussed. We want to be paid, or we want the provider to be paid as if the visit were provided in person. And then during the PHE, this public health emergency, the CPT telehealth modifier 95 should be applied to each claim line that describes services furnished via telehealth or telemedicine. And that's an important one. Keep in mind what it is saying. For each line item of service that is provided through a telemedicine visit, we want to add that modifier 95. So I'm going to change from telehealth now and talk for just a few minutes about a virtual patient check-in. And again, I don't want you to be concerned about the code so much as simply understanding the type of service or the definition of the particular patient service, how it can be provided, and the information that you need in order to be able to charge and bill. So a virtual patient check-in is a brief communication service, 5 to 10 minutes with the practitioner via numerous communication technology modalities, including synchronous telephone or exchange of information through video or image. Two requirements that we had prior to the public health emergency. CMS has let us know that not during the PHE, the patient does not have to initiate the virtual service, and the patient does not have to be an established patient. So those two are important that we understand. But that third bullet we do want to pay attention to. This virtual check-in can only be billed if the communication is not related to a medical visit within the previous 7 days and does not lead to a medical visit within the next 24 hours with the practitioner or professional or soonest available appointment. And so just so you can use this particular presentation as a reference guide, you'll see there the codes themselves and the definitions as they come to us. On the next slide, I have two examples, and I certainly am not going to try to go through all of this information, but another question that I get quite frequently is, okay, Linda, we do want to charge for these virtual visits, but give us an example of what you're talking about. So as you see there on this particular slide, we have an example of both codes for you to review, or perhaps for your charge posters or your office team members, your outpatient locations to review, to understand what is a virtual visit, those 5 to 10 minutes, what are generally they spent on providing to the patient. So I wanted to give you examples for reference. Here are the CMS requirements. As we've said, it does require verbal interaction with the patient. It can be audio only, but it must be real-time interaction with the patient. It can be synchronous, two-way, audio enhanced with video, just like we've been using for telehealth. There may be a verbal follow-up option for the code that you see there, which could be a phone call, audio, video, even secure text messaging, email, or patient portal communication. So think about the avenues of being able to provide this particular service to patients that these open up. As we talked about, patient consent must be documented, can be verbal, and CMS did let us know that this particular consent can be for a period of time. So I would suggest that in January, you begin asking for consent for the calendar year of 2021. Again, this particular virtual visit must not be related to any global surgical period. It can be part of an opioid or substance use disorder treatment regimen, for example, medication-assisted therapy, and I am seeing those opioid and substance use disorder treatment programs now coming back to life because of the technology-based services that are being allowed instead of that in-person visit. There are no frequency limitations for these two particular services. And as I mentioned to you, There is both a professional and a technical or facility component, so that's good news for us in hospitals. Rural health clinics and our federally qualified health centers may be paid for these in addition to the encounter rate, but they would use that HCPCS Level 2 code you see there, G0071. I'll stop for a second and just see if we have any questions in the Q&A that you want me to stop to answer. Okay, I will continue. This question is about what does it mean for these technology-based services to be initiated by the patient, and we did talk about that one. This means the patient must consent to the service either before or at the same time that it takes place. It does not prohibit practitioners from educating on our own initiative beneficiaries on the availability of the service prior to or at the same time that the service is taking place. And I do think that's an important clarification for us. I'll mention again the bundling, and I won't go into this into a lot of detail, but just make sure that you look at these particular slides to know that if a technology-based service is provided at the same time that it leads to an E&M service, as we mentioned, with the same physician, then it's going to consider to be bundled into the pre or post visit time of the associated evaluation and management service. So same physician, not separately billable. However, when this technology-based service or brief virtual visit leads to an evaluation and management visit with a different physician or other qualified healthcare professional, then it would not be bundled and it would be separately billable. And that's the same whether we are in a public health emergency or not. We have followed that particular guideline in the past. I did get the question just a couple of weeks ago, can these two codes or these two services be charged and billed on the same day? And CMS has answered and said, yes, both codes can be charged and billed on the same day as long as the time is not overlapping. In other words, I need my documentation for the first service and the time, and then I need my documentation for the second service with time that is not overlapping. And then I'll change and talk about non-face-to-face e-visits. Now, again, here is where I think the services get a little bit confusing because we have virtual visits and now we have e-visits. So Medicare has established that patients may have non-face-to-face patient-initiated communications with their providers without going to the office by using online patient portals. Notice that the definition there is a patient-initiated digital communication that does require a clinical decision that otherwise would have typically been provided in the professional's office. So for these e-visits, most often through a patient portal, the patients must generate the initial inquiry and communications can occur over a 7-day period. So I have 6 new codes to share with you, and I'll only mention that we have 3 for use by the physician or other qualified healthcare professional. Remember, we said physician assistant or nurse practitioner. And then we also have 3 for digital communications with a non-physician healthcare professional. So remember our list back in the previous slide that for those additional practitioners, these codes can be used for that non-face-to-face e-visit. And also Medicare has given us 3 new HCPCS Level 2 codes, and I apologize, so much information about codes, but think about the service itself. For an established patient for up to 7 days of cumulative time, and you see the minutes there, we would select the appropriate code, either your charge poster, whoever may be entering the charges, or your coder, or sometimes the individual within your physician office who is deciding on the service to be charged and billed, we want to select the code based on documented cumulative time for these 6 CPT codes and the 3 HCPCS Level 2 codes, documented cumulative time during the 7-day period. And as you see there for those codes for Medicare, they are payer specific in that circumstance. And this is just, again, a reference slide to give you the minutes and the codes themselves with the actual definitions so that you can pull this up if you want more specific information. And these are the Medicare specific codes for that qualified non-physician professional. I'm going to change now and look at some series of services I think are important, particularly for our professional providers, because these lend themselves to providing patient services that probably have been provided in person in the past that now, of course, can be provided through those communications-based technology services. So this first one is Principal Care Management Services. Patients must meet the following criteria. They must have one complex chronic condition that has lasted or will last at least 3 months. The condition must be severe enough that the patient is at risk for hospitalization, perhaps was recently hospitalized due to the condition. The condition requires development or revision of a disease-specific care plan, and the condition requires frequent adjustments in the medication regimen, or the management of the condition is unusually complex due to patient comorbidities. So this is principal care management for that patient with a complex chronic condition. And if you think about particularly our Medicare beneficiaries, they often have at least one, if not more, chronic conditions. So this particular service requires 30 minutes of provider time each calendar month, and this is a professional payment only for this particular code. But again, extremely important that we understand, are our inpatient patient care services being replaced by our technology-based, and are we charging and billing appropriately? So now I will change to another code that requires 30 minutes of clinical staff time. So I have a specific HCPCS Level 2 code for the physician or the professional, and now I also have a HCPCS Level 2 code for clinical staff time that has been directed by a provider during the calendar month for patient care. The provider having to give general supervision does not require the provider to be on site while the clinical staff performs the service. These codes, as mentioned, can be billed monthly in addition to any appropriate evaluation and management codes that may have been provided to the patient. The 30 minutes of provider or clinical staff time does not have to be face-to-face, but can be time that has been used to create patient care plans, used to follow up with patients via phone or other technology-based communication services with the patient. Now, this particular code does have a technical or facility component that is reimbursed by Medicare for next year at $75.26. So I just want to get across that understanding telehealth, and I know I've said this to you before, is not just professional services. We want to be looking at the services provided, matching the service with the appropriate definition, finding that code, and then understanding if it is being provided in a hospital outpatient area, in a provider-based clinic. Is there a technical or facility component that should be charged on my hospital UB04 claim? So I'll change from principal care to chronic care management. Systematic assessment of the patient's medical, functional, and psychosocial needs, and you see the requirements there. I think medication reconciliation with review of how the patient is adhering to their medication is particularly important because I am seeing, and especially now, I am hearing from our hospital clinics that patients are requesting more virtual or technology-based services as they are attempting to have their medication adjusted for their chronic conditions. This particular chronic care management does require oversight of patient self-management of medications. It also allows for coordinating care with home and community-based clinical services providers. So let's read some more about this one. We'll start out with CPT code there for chronic care management services, at least 20 minutes of clinical staff time that is directed by a physician per calendar month that has the following required elements. And again, you'll see what's required there. This code is being revised for 2021. Remember, our CPT code revisions take place on January 1. So now this particular 99490 code for chronic care management will be for the first 20 minutes of clinical staff time. And then we also have a code for physician of at least 30 minutes of time per month for chronic care management. So again, if you have questions, we'll go into a little more detail, but please reach out to me if I can answer any questions you may have. In addition, for 2021, we have a new code. As you see there, for chronic care management with the following required elements: multiple 2 or more chronic conditions, expected to last at least 12 months, does place the patient at significant risk, and that may not be death, it may be simply an exacerbation or decompensation of the patient's ability to care for himself or herself. This requires, as you know, in the past, chronic care management has required a comprehensive care plan to be established, implemented, revised, or monitored. And this code is for each additional 20 minutes of clinical staff time directed by the physician. So when we're looking at both the two codes you see there for clinical staff time, they do have technical or facility components for 2021 reimbursement. I'll change now from chronic care management to what is called complex. And I'm not going to read this to you because I know our time is limited, but I think if you will just look at what's required and then understand my documentation, I want it to be requested by the template that I am using to include the details that are needed to make the decision about what can be charged and billed. So you see there the first code for complex chronic care management, and then we have a code for each additional 30 minutes of clinical staff time that we're going to list separately in addition to the code for primary procedure. And I know this does sound confusing, but as I said, I think if you will simply follow the slides, the information, look at the documentation that you have, or even discuss with your providers the services that patients are requesting or that you are offering to patients, then these will fall into place. We do have a revision for that 99487. Notice that it says it can be establishment or revision of that comprehensive care plan. And I think that's an important one to us because often that comprehensive patient care plan, particularly for complex chronic care management, it's, to me, when I look at a medical record, sometimes these are revised almost on a weekly basis. So difficult to care for that patient with complex chronic care. And as you see there, 2 or more chronic conditions. And then I am surprised when I'm reviewing particularly Medicare beneficiaries, how many patients are experiencing more than two and even multiple chronic care. This one looks at chronic, complex chronic care, less than 60 minutes, and then what cannot be reported separately. Both of those two codes that I've mentioned to you do have facility components. We aren't going to report care management services of less than 30 minutes in addition to the first 60 minutes of complex care. And notice that that one code down at the bottom bullet includes only time that is spent personally by the billing practitioner. So we want to be sure our documentation clearly indicates, and generally it does because it would be signed by the professional, but we want to be sure that if we have clinical staff time, that is also clearly indicated so that we are charging and billing the appropriate service to be reimbursed. And then we have these codes that is time spent directly by the billing practitioner or clinical staff counts toward the threshold of clinical staff time. And that's a question that I got asked just about a month ago. So in putting these codes together, again, understanding who's providing the chronic care management and the time being spent is what is going to guide, or actually what is going to dictate what we are charging and billing for. So I do give you some additional billing tips there on that particular slide. I'll change from complex chronic care management to transitional care, and I am seeing this one used more and more frequently. These, of course, are services for an established patient whose medical or psychosocial problems require moderate or high complexity medical decision making during the patient's transition, as you see there, perhaps from inpatient hospital care, or it perhaps could be a rehab hospital, or even long-term acute care. The patient is being transitioned from one care setting to another, to the patient's community setting, which might be their home, the domiciliary, rest home, or assisted living. So understanding transitional care, particularly for your providers, I think will open up those opportunities of additional reimbursement. There is a technical or facility component to these transitional care management services. And again, I won't go into all the details, but keep in mind how often a patient is transitioned from inpatient, or I'm seeing more patients transitioned from rehab to their home care setting, and the services that are being provided can now be provided through those technology-based services that we're talking about after one face-to-face visit within the specified time frames. I bring that up because I would like you to see in this slide, remember that we're talking about a patient who does have moderate complexity or either high complexity. There must be one face-to-face visit for the codes that you see there, and the high complexity requires the visit within 7 days, and the moderate may take place within 8 to 14 days. That medical decision making, of course, we're going to review the Evaluation and Management Services Guidelines to make sure that we're understanding and appropriately assigning moderate and high complexity. Documentation should include the timing of the initial post-discharge communication with the patient or caregiver, the date of the face-to-face visit, and the complexity. Is it moderate or high? Only one individual may report these services, and only once per patient within 30 days of the patient being discharged from that inpatient setting to their home setting. This slide is all about selecting the appropriate code, and as you see there, the only difference is, as I mentioned, the moderate complexity can have a face-to-face visit within 14 days, and the high complexity requires that face-to-face within 7 calendar days of discharge. I'm going to change again. And remember, I mentioned to you, there are about 9 or 10 different types of services or definitions of services within this presentation that you may want to consider should you be providing in order to meet your patient needs. So this is called the collaborative care model, and it is primarily a behavioral health integration model. We do have specific codes for it. So this collaborative care model provides behavioral health integration that enhances the usual primary care by adding 2 key services to those primary care services, particularly for those patients whose conditions may not be improving, care management support for patients receiving behavioral health treatment, and then also regular psychiatric, what's called interspecialty consultations. So to be able to provide these services, to charge and bill under the collaborative care model, we need a team of 3 individuals: behavioral health care manager, the psychiatric consultant that I mentioned to you, and then we need our treating, who is the billing physician or practitioner. Again, a little complicated, but if you simply review the requirements and understand what's happening, particularly within your mental health or behavioral health areas, I think that you will find, I talked to 2 hospitals just 2 weeks ago, I think, that were already providing this type of service, a behavioral health care manager, along with a psychiatrist. They simply were not understanding that these services now have particular codes that can be charged and billed. What's required, of course, the initial assessment, initiating visit. If required, it can be separately charged and billed. Administration of an applicable validated rating scale, and we see that often in behavioral health. Certainly systematic assessment and monitoring of the patient using those applicable validated clinical rating scales that we use in mental and behavioral health. We need care planning by the primary care team jointly with the patient. Also, of course, there may be care plan revisions whose patient's condition is not improving. And we simply want to be sure that this particular patient is receiving care facilitation and coordination between these 3 individuals: the primary care provider, the behavioral health care manager, and the psychiatrist. It should be a continuous relationship with a designated member of the care team. And again, both professional and technical components are available for payment coming up for 2021. If we're going to switch now and not have that collaborative care model, we do have a code to bill monthly services for services or patient care that does not have that collaborative care. That similarly include core service elements, but do not have that continuous relationship with a designated care team member. So I'm moving from the previous slide for collaborative care management simply to charging and billing for services that are being furnished in behavioral health that neither a psychiatric consultant nor a designated behavioral health care manager is involved. So this is a more, I think, limited service in behavioral health. But again, I am hearing that these services are being provided. And as you see there, there is a facility component for next year. I'll change over to the opioid substance abuse disorders. Now, these are office codes, or what Medicare calls professional service codes for Medicare beneficiaries. And as you'll see there, the HCPCS Level 2 codes. Now, these are to be accepted both by traditional Medicare and Medicare Advantage plans. And I get that question often. But yes, when you see CMS furnish a particular HCPCS Level 2 code, then yes, that should be accepted and paid by your Medicare Advantage plan. Now, when I say that to you, you're going to show me a contract that may be different. But if you keep in mind, we can go to the Medicare guideline and provide the regulation or the information that says, yes, these particular services should be reimbursed for a Medicare Advantage patient. That still is going to have to be an appeal, or it's going to have to be a letter in order for you to obtain that payment. Again, if you have questions, please let me know, because I can give you some examples of how that can be done. These three codes do describe new bundled services for the treatment of opioid use disorders. CMS, that quote comes from them, says, "We hope to incentivize increased provision of counseling and care coordination for patients with opioid or substance abuse disorders in the office setting, thereby expanding access to the needed care." So again, here are the three codes, the complete definitions, and the facility payment for what's coming up in 2021. I'm going to spend just a second or two on Medicare remote physiologic monitoring. Medicare answered the question for us, can these be provided to new patients as well as established patients? And CMS has said yes, starting back with the public health emergency, these services can be furnished to both new and established patients. CMS has suspended, under these circumstances, the requirement that there be an established relationship. Okay, here are the services for remote physiologic monitoring. And I know that a lot of you are already charging and billing these, so I won't spend a lot of time on them. But keeping in mind, they are specific definitions for the service being provided, whether or not it is a clinical care provider or the actual physician or professional himself or herself. What is required by CMS? The use of a medical device as defined by the FDA does require a prescription by a physician or other qualified healthcare provider. The threshold is 16 days that the patient is being monitored or is wearing the device, is how I would look at that one. These would not be reported when part of another monitoring service, such as continuous glucose monitoring, that you may already be charging and billing for. The code is reported once for each patient episode. It does begin when monitoring is initiated, ends with the attainment of the patient's targeted treatment goals, or when the patient discontinues the use of the device. And again, I'd just like to tell you about the facility component for 2021. This one is 99457 that can be reported in conjunction with those care management services that we've already reviewed. And see, I think this one is important because if you're providing chronic care management in any of these settings, then if you want to also have a remote device that is being monitored, they can be charged and billed together or in conjunction with. Again, as always, the time should not overlap, so your documentation should clearly delineate what service is being provided and start and stop times. But I do think it's important that we understand both can be provided and charged and billed. The one question I get, can practitioners provide Medicare telehealth services using their phones? CMS has answered and said yes for use of certain phones that have audio and video capabilities for furnishing Medicare telehealth services during this public health emergency. And Medicare actually, or CMS actually gave us some examples. So you see there, Apple FaceTime, Facebook Messenger video chat, Google Hangouts even for video, or Skype. So extremely important that we not limit how we are providing these services. And again, I have given you the website from straight from CMS if you want to read more about these particular telephone chargeable and billable services. Now we can change over to actual telephone only services, and these are the codes that we have, where we have no video, that are reimbursable by Medicare and private payers during the public health emergency. We would not, another question I get frequently is, we would not use the telemedicine modifier 95 because these are telephone only and are not considered to be telemedicine. Again, you would use your normal place of service on your 1500 claim for your professional billing. And this was a new policy that we got back in March, that these codes are covered and can be billed back, of course, to March 1st. So these are telephone only, and we are using our smartphones or other technology-based services for telehealth that have the video capability. What about beneficiaries who do not have access to those smartphones or technology? Physicians and other practitioners are allowed to bill for certain telephone assessment, evaluation, and management services during the health emergency. These were not separately billable before, and they can be billed for both new and established patients. These are the audio only services that I showed you with the time limitations shown there that would determine your charge, of course. That is a tremendous amount of information. So thank you for your attention. And I think this slide continues to remind me of the processes that we can go through in order to increase cash for 2021. I think educating our clinical leaders, our certainly clinical care teams, physicians, other providers, and also our revenue cycle teams. We, on the what I call the revenue cycle side, need to be sharing all of this information with our clinical leaders and teams so that we understand the new patient service opportunities, so that we are meeting patient needs, but at the same time, we are understanding what can be charged and billed for, so that we are adding these services to our charge master. We do want to encourage those technology-based interactions that we've discussed, perhaps discuss scheduling opportunities for all of these virtual services that we now know are chargeable. And then we need to go back and make sure our order entry, being able to capture the charges. I mentioned to you the charge description master. Our coders, of course, most often have the codes because they are generally educated on new codes. But now we want to also educate our coding team on different opportunities for using these particular codes. Certainly billing must be educated because we have changed not only what is billable, but we have new billing guidelines in place. We want to make sure that all of us within the patient care arena, whether we're clinical or professional or revenue cycle, we want to make sure that we understand now routine care in all outpatient hospital locations, whether we call them clinics or whether we call them, simply an outpatient department, and particularly in our physicians' offices, if those are employed physicians, that all of this information is available. We want to make use of it, and we certainly want to charge and bill those services that we are providing. Also, for our COVID-19 specialized services, both inpatient and outpatient testing, we want to understand that our ability to capture these charges, as you see there, through order entry, charge capture, CDM, coding and billing, all of our workflows are in place so that we are capturing this revenue and being paid. I think you do need a knowledgeable analyst, probably more than one, to simply work on reviewing documentation, look at the charges that are being posted, both codes and modifiers, and then diagnoses even, to make sure that we're optimizing reimbursement. I'm seeing this service being provided by revenue cycle teams with both coders and documentation specialists often, and simply including knowledgeable billers so that we understand, again, and I've said it to you so many times, the service is being provided, and are we charging and billing appropriately? And I am seeing, or I'm hearing from our hospitals and our physicians, there is a great reward for meeting patient needs in these very difficult times, particularly for those patients with chronic illnesses, comorbid conditions, certainly looking at substance abuse. Some of those programs were discontinued when we first, first came into the public health emergency, but simply asking all the questions, I think, is what is important. What services are we providing? What should we be providing through our technology-based services? And what codes, definitions are there so that we can educate appropriately? I will stop now and see what kind of questions you may have.
Thank you, Linda. Great information as always. And I apologize, I didn't get myself off mute fast enough when you had paused for questions earlier, but there weren't any in the box, and we don't have any now. I'll let everybody just have a minute if there are any to type in. But while we do that, if you wouldn't mind extending to the next slide, I know the slide deck will be sent out, so your contact information will be there, but also want to take a moment to thank our Hawaii chapter sponsors for 2020. As you can see here on the screen, I know we're a couple minutes over, so just giving a moment here to check in on Q&A. Otherwise, as Linda stated, please feel free to reach out to her with questions. Her contact information is in the slide deck, which will be distributed, as well as the recording. And thank you all again for joining. Please be on the lookout for more communication about our next Region 11 webinar, which will be happening in February. And thank you again, and happy holidays, everybody.
Thank you all. And let me thank quickly, Kimberly George is on the call with us, and I appreciate her being here. She is our Western Business Development Representative, and she is the only one I know that sticks with me through all of these presentations. So thank you very much, Kimberly.
Thank you, everyone. Thanks, Linda.
And oh, you are welcome. And let me say thank you to HFMA as well. I just appreciate the opportunity not only to present, but the terrific education that you provide. So thank you very much. And happy holidays.